3:04 in the morning. A nurse named Brian walked into a room on the obstetric ward, and a patient who had not spoken coherently in 2 days looked at him and said, very clearly, "Open the window. Colleen wants out." The patient was 108 years old. Her name was Colleen. Brian had never told her his name. He had been on her ward for a total of 3 shifts, and she was, Brian checked later when he could not let this go. She was the only Colleen in the building. He opened the window. She was gone by 4. This is Hollow Atlas. Every episode we go to one real place. We tell you what happened there. We stay with the facts that can be sourced, and with the facts that can't. Tonight the place is a building you've almost certainly been inside. Maybe one you were born in. Maybe one where somebody you loved didn't make it out. A hospital. Not at noon when it sounds like a market. At 3 in the morning when it sounds like nothing at all. There is a reason nurses who have worked 30 years call this hour the witching hour. Part of the reason is biology. We'll prove that with peer-reviewed research in a moment. And part of the reason is something nobody on the floor wants to name. But that senior staff in a large enough hospital, all the way across the world, tell the same 4 stories about. So that is the question we are going to sit with tonight. Why, in every language, in every country, in every hospital system old enough to have kept a record, is it this hour? Start with the boring part. The part that is not supposed to be scary. In 2024, a study published in the National Library of Medicine tracked 155 nurses, 50 in emergency, 53 in intensive care, 52 in internal and surgical wards. Every hour, through an entire night shift, researchers measured how sleepy each nurse was, a clinical metric, the visual analog scale of sleepiness. The graph looks like a hill. Sleepiness rises after midnight. It keeps rising. It peaks at 5 in the morning, at a score of almost 50 on a 100-point scale. But the curve starts climbing fast around 2 a.m., and by 3, the human body is somewhere it was never designed to be awake. Core body temperature is at its lowest. Cortisol, the hormone that gets you out of bed, hasn't kicked in. Melatonin, the one that tells your brain it's night, is still flooding the system. Reaction time, in multiple peer-reviewed studies, drops to roughly what you'd see in a driver at the legal limit for alcohol. This is the window where more medical errors happen. It is the window where more patients code. It is the window where, in a hospital large enough, something will go wrong tonight. And it is the window where nurses, awake, vigilant, usually alone on a floor, keep telling the same handful of stories, across every continent they work in, across every decade for which we have records. 4 of them. Listen carefully to where they overlap. Jerry F. is a registered nurse. The unit was pediatric. The building was pre-war, one of the oldest wings still in clinical use. Tile floor that remembered every footstep. Just after 3 in the morning, one of her patients, a 7-year-old boy, 2 days post-op, woke up and asked her very calmly about the doctor. Jerry asked which doctor. The tall one, the child said. With the grey hair. He was just in here. No physician on the unit that night matched the description. Jerry checked the badge log. She checked the 2 neighboring wards. She walked the entire floor. The tall, grey-haired doctor did not exist. The child described his tie, his glasses, the way he leaned down to check the IV line. The boy was not delirious. He was not febrile. He was a child, post-op, yes, but neurologically intact, telling his nurse about a person who had been in his room. A week later, a different child, different diagnosis, different family, different parents, on the same floor, asked Jerry the same question. Where did the tall doctor go? Jerry does not believe in ghosts. She does believe that 2 children, a week apart, in the same building, described the same man in the same detail. She keeps working there. She stopped asking. Jamie N was 12 years into ICU work. Every unit she had ever been in. Same setup. A wall behind the station. Chart slots. You pull the binder. You write the note. You put it back. 3 in the morning. She was at the computer, charting a patient in Bay 4. She heard it before she saw it. Every chart on the wall, 20, maybe 30 of them, came off the shelf at once. Not one, not 2 or 3 falling and knocking the others down. All of them, simultaneously, binders and all, as if pushed by a row of invisible hands working in rhythm. She did what any ICU nurse does when something incomprehensible happens at 3 in the morning. She finished the note. She picked the charts up. She refiled them. She checked on her patients. Nobody was coding. Nothing on the floor had shifted. There was no earthquake that night. She checked. There was no truck in the loading dock. 6 years later, she published the story in a national nursing magazine. She still does not explain it. She just says, "It happened." We are going to pause the individual stories now, because something is about to change about this episode, and I want you to notice when it does. Up to this point, you have heard 3 anecdotes. Each one, on its own, is dismissible. Tired nurses, dim light, a child's imagination, coincidence. But there is a pattern that shows up in more than one hospital. And patterns are what make nurses, senior nurses, people who have seen everything, stop using the word coincidence. At a hospital in Denver, older building, demolished in the early 2000s, night shift nurses, over the course of years, noticed something. Patients who were about to crash, about to arrest, about to code, would sometimes in the hour before ask the staff about a child in the hallway. A little girl, in a red dress. They were not delirious. They were not sundowning. Many of them were fully oriented, awake, alert, describing a child politely, asking who she was, wondering why she was on the floor this late. The nurses, senior staff, not new grads, started treating the mention of the girl as a clinical signal. When a patient brought her up, the charge nurse pulled the crash cart closer to the room. Not every time. Often enough that by the late 1990s, it had become an unwritten step in the pre-code workflow on that unit. There is no peer-reviewed study on the Denver girl. No paper you can cite. No journal will touch this. There is only the institutional memory of experienced nurses across 20-plus years of shift rotations who learned, the hard way, to listen when a patient mentioned her. That is where this episode changes. Because if you can dismiss 1 story, and 2 stories and 3, it is much harder to dismiss a reproducible clinical signal that nurses across 2 decades started actually using. Dora C. was alone at the station. 3:10 in the morning. Her unit was quiet. No new admissions, no active codes. She was charting, the kind of administrative catch-up every night shift nurse does in the lull between rounds, and then someone said her name, not loud, not over the intercom. A whisper. Close enough, within arm's reach, that she should have seen the person saying it. She turned. Nothing. She got up. She walked the hall. She checked every patient room. Every patient was asleep. The only other staff member on shift that night was in the break room on the opposite end of the building. Dora timed it later. That nurse could not have been near her station, could not have spoken, would have had to cross 3 corridors and a set of fire doors to be anywhere close enough to whisper. She came back to the station. The chair was still warm. The whisper came again. Her name, same voice. Dora left the hospital 3 weeks later. Not the profession, the building,